Hi, I'm Jack Cush, Executive Editor of RheumNow.com. This is the RheumNow Weekend Review. It is the 24th of February, 2017. From the Newswire this week, a study of over 34,000, actually 43,000 psoriasis, psoriatic arthritis, and ankylosing spondylitis patients looked at the incidence of depression, suicide, and suicidal ideation. Interestingly, they found a significant increase in depression for psoriasis patients of 14%. That was significant for psoriatic arthritis, 22% increased, and 34% increase in depression in ankylosing spondylitis patients. What they did not see was an increase in suicidal ideation or suicide in those patient cohorts. Sort of supports a lot of the comorbidity data that's out there. A recent review looked at the diagnosis of scleroderma renal crisis and came up with some criteria that may be differentiating. This includes hypertension, acute kidney injury, encephalopathy, seizures, microangiopathic hemolytic anemia, to name a few. A study of 183 patients with lupus who were treated with mycophenolate tried to identify those clinical predictive factors, whether it be symptoms or labs or signs, that might predict who would respond to mycophenolate. In fact, they could not identify any, suggesting a greater need for research in this area about how we can better choose the therapies we use to treat lupus. As you know, last week we were at the RWCS meeting in Maui run by Artie Cavanaugh. Great meeting. A number of tidbits from that meeting come from some of the speakers. Dr. Marty Bergman, we tweeted about his incredibly insightful lecture about adherence and compliance, showing just how poor people are. Greater than 50% non-compliance or non-adherence rates in many of our patients. And basically his end point was, you need a game, you need a strategy, you need a specific way as to how you're going to forestall the temptation to be non-compliant with medications prescribed. A recent analysis of cancer and biologics showed that amongst the many biologics that we use, there was no increase in cancer when you look at infliximab, etanercept, adalimumab, abatacept, rituximab, tocilizumab, and tofacitinib. In all of these, the odds ratios range from 0.9, 0.58, 0.93, 0.60, 1.15, as high as 1.68 for actually infliximab, but none of those were significant. All of those overlapped with 1. Another interesting set of lectures came last week at RWCS from Uma Mahadevan from UCSF. She actually showed a nice slide that GI doctors spend as much time with prior authorizations as do rheumatologists, such that 63% are using at least a 25% FTE, or a quarter of a nurse's time, to accommodate what is at least 5 phone calls a day. They find that at least 73% of practices have greater than 5 phone calls a day, and as much as 37% have greater than 10 phone calls a day to get prior authorizations done. It's a beating, it's something that's uncompensated time, it's a problem throughout medicine. The CDC has reported this week that the peak in the seasonal flu has actually arrived, second week in February, and will continue for the next 3 or 4 weeks at least, and then will steeply decline thereafter. Hence, it's almost at the end of the time when you need to vaccinate your patients. Again, Dr. Mahadevan looked at the critical issue of PPI use, and we actually reported that in RheumNow.com based on a number of FDA warnings, but she took a more pragmatic approach and showed that when you look at some of the things that have been linked to PPI use, like C. diff diarrhea, that in fact the risk of that is about 1 in 2,000 for those who are on chronic PPIs. Likewise, the risk of osteoporosis, also, actually the risk of C. diff was 1 in 4,000. The risk of fractures from osteoporosis is only about 1 in 2,000. So it's a matter of perspective, obviously. You should be wary about patients who may be at risk for these things, but it's certainly not a common side effect to PPI use. Dr. Cavanaugh, in one of his presentations, showed a very insightful head-to-head study where etanercept was compared to apremilast in patients with psoriasis, showing that the response rates were pretty much the same, about 40%, 45%, not a great deal of difference between those. So for those of you who think that apremilast may not be effective, it certainly works as well as etanercept in those situations. Kevin Winthrop and I did a great video that you should look at on the RheumNow website and also on the RWCS website. Kevin gave a good lecture on vaccines and infectious issues, and he basically said that there are a lot of drugs that affect vaccines. The drug that most likely to affect vaccine response is rituximab. Obviously, you want to get your vaccinations done prior to using rituximab, and maybe the drug that's least affecting the vaccine response is methotrexate. And there can be some blunted responses, but methotrexate, obviously, it's very safe to give vaccines in that setting. Last week, the FDA did approve the third IL-17 inhibitor, brodalumab, originally developed by AstraZeneca and Amgen and abandoned because of the risks of depression and suicide, which we talked about at the top end of this broadcast. But nonetheless was approved by the FDA for moderate to severe plaque psoriasis this past week. However, it comes with a box warning for suicide. Moreover, it comes with a very aggressive REMS program that patients are going to need to be registered. Doctors are going to have to be certified to use the drug. Hard to say how much use it's going to get. Olumiant or baricitinib was approved by the EMA last week in Europe for use in moderate to severe rheumatoid arthritis as monotherapy or as combination therapy with methotrexate. The recommended starting dose there is going to be 4 milligrams per day, and it can go down to 2 based on certain scenarios. Baricitinib was also in the news last week with the BEAM study showing its efficacy against placebo and against adalimumab showing its superiority, which is a one-up for them because tofacitinib was reported last week to actually only be equal to adalimumab when combined with methotrexate. Tofacitinib as monotherapy is not as effective as tofacitinib with methotrexate, nor as effective as adalimumab with methotrexate. This week we reported in the news a higher rate of hip and knee revision surgeries in those who had arthroplasties that were under age 50 or under. That the rates of revisions are only 5%, regardless of whether it's for RA or OA, in those over the age of 70. But if you look at a younger population under age 50, it goes up as high as 35% in males and 20% in women. So maybe suggesting that we should rethink our use of arthroplasties in younger individuals. Sirukumab was in the news this week in Lancet, a study showing its moderate efficacy in rheumatoid arthritis patients. This was the SURROUND-T study, and while 2 different dosing regimens were superior to placebo, roughly 40-45% versus about 20-24% for placebo, the results were not stellar. But then again, if you look at the patients going into the study, a significant amount of them had received TNF inhibitors previously. Only 80% of them were on DMARDs as background therapy during the study. It was a mixed bag of patients, and maybe that's the explanation for some less than expected results in that particular trial. So that's it for this week at rheumnow.com. Tune in next week. Go to the website to find more information and the links to these particular citations. Have a good weekend. Bye.